share updates on several of our NIH clinical trials. And so the first will be, as we've heard a fair bit about Denosumab today and yesterday, so just as a brief background, Denosumab acts through a protein called RANKL, receptor activator of nuclear kappa B ligand. This is a protein that's a member of the tumor necrosis factor superfamily. It's highly expressed by osteoblasts and osteoprogenitor cells, and it exists in both soluble and transmembrane forms, all of which participate in osteoclastogenesis. So by binding to its receptor RANK on osteoclast precursors, it activates the differentiation and fusion of mature osteoclasts. And we've been interested in this protein in fibrous dysplasia for a while because we have growing evidence that it may play a role in pathogenesis. So we see increased RANKL levels in patients with FD, and those levels appear to correlate with the amount of FD that someone has. We see high levels of RANKL expression in FD tissue, and that expression appears to correlate with areas that are highly proliferative. As you can see here, it appears to co-localize with areas of Ki67 staining, a proliferation marker in serial sections. And of course, this is highly relevant clinically because RANKL is something we can target with a commercially available medication. Denosumab is a monoclonal antibody to RANKL that interferes with its relationship with its receptor and inhibits the differentiation and fusion of osteoclasts. So we hypothesized that RANKL inhibition with Denosumab would serve as a novel treatment strategy to decrease the activity of FD lesions and also increase the bone formation within them. So we performed a phase 2 study of Denosumab in adults with FD. The results of this were published earlier this year, and I shared some of this data at the patient event yesterday, so apologies if there's any repetitiveness. So we used the high-dose Denosumab formulation, the ex-Giva dosing, which was developed for bone tumors, and it was 120 milligrams monthly with loading doses on weeks 2 and 3. So 8 adults were treated with high-dose Denosumab for 6 months. Now, when Denosumab is stopped, its effects are transient. So there's a temporary rebound of bone turnover that can exceed pretreatment levels. So because of that, it was very important to us in this study to also investigate the safety of Denosumab discontinuation. So we had an extensive post-discontinuation monitoring period. So the primary endpoint of this study was bone turnover markers, P1 and P, a formation marker, and CTX, a resorption marker. Our secondary endpoints included effects on radiographic lesion activity, pain and function, and we performed FD lesion bone biopsies at baseline in 6 months in the same lesion to look at histologic effects. So at the end of the 6-month treatment period, we saw just a dramatic decline in bone turnover markers. Interestingly, our bone formation marker, P1 and P, declined just as much, if not more, than our resorption marker, CTX, so suggesting that Denosumab was affecting not only osteoclasts, which we knew it could do, but also the bone-forming cells in FD. Sodium fluoride PET-CT is a combined functional and anatomical imaging technique. It can quantify the amount of tracer that's being taken up within the FD lesions, which is a measure of how active they are. And we saw large declines in the amount of tracer that was taken up at the 6-month time point. And this also correlated with improvements in self-reported bone pain and in physical function measures. The physical function improvement was different in every patient. The patient here on the lower left corner, who has severe rib FD, actually had pulmonary restriction due to the expansion of the ribs and had required supplemental oxygen therapy. And she was able to stop oxygen and had improvement in pulmonary function tests after Denosumab. We had another patient that had very aggressive skull base expansion, had multiple optic nerve decompression surgeries, and her vision stabilized for the first time in 5 years. So that was very encouraging. I do want to emphasize, though, that the way we measured lesion volume using this technique was via tracer uptake. So we were looking at the volume of metabolically active lesions. As Dr. Pan shared, this is in contrast to the volume of dysplastic tissue. That's something that needs to be measured with CT. So we did not show that the actual dysplastic area of the lesion shrunk. So I don't think this study does not indicate that we can, quote unquote, shrink FD lesions, but we can impact their metabolic activity. This slide shows the results of our pre and post-treatment FD lesion biopsies. So we saw an increase in bone content or formation of mineralized tissue within the lesions. We saw a decreased expression of the proliferation marker, MCM2, and increased expression of the mature osteogenic marker, SOST. So when we put all of this together, it really seems to support a model where denosumab is inhibiting the proliferation of these abnormal osteogenic cells and thus allowing them to adopt a more mature differentiation pattern, which can allow them to make more bone. So conclusions from this portion of our analysis were that RANKL inhibition decreases cellularity, increases maturation of FD cells, and what's exciting is this really supports the therapeutic use of denosumab beyond its expected anti-resorptive effects. It also highlights the important role of osteoclast to osteoblast signaling as a key aspect of FD pathophysiology. So this is quite exciting. However, we did run into important issues with bone turnover rebound. So all patients received zeledronate at the time of denosumab discontinuation in an effort to try to mitigate bone turnover rebound. In half of patients, 4 of the 8, CTX rebounded to above pretreatment levels. And in one subject, this was extremely severe. She was the patient that had the highest baseline bone turnover in the cohort, and within a few months of stopping denosumab had developed CTX 6 times her pretreatment level, which was associated with severe hypercalcemia to 23 milligrams per deciliter. So she was hospitalized, she was treated with IV fluids, zeledronate, more denosumab, and she recovered without sequelae. But this is obviously an important adverse effect that we need to be aware of. So denosumab for FD, where are we now? At this point, I think there's clearly exciting potential for effects on FD lesion activity and composition. However, severe post-discontinuation hypercalcemia occurs in at minimum a small subset of patients and is an important consideration. So there are a number of questions that I think we really need to prioritize answering. Who should we treat? This is clearly not a medication for everyone with fibrous dysplasia. The side effect profile is not favorable enough for that. However, I think it really has real potentially powerful use in patients with highly morbid disease. And how long should we treat patients? I think one helpful finding from our study is that to maintain benefits, you really have to continue treatment, and you cannot expect to maintain any benefits after the medication is stopped. So whenever we start denosumab, we have to plan for long-term treatment. And what is the optimal dose? We saw really powerful effects in only 6 months on this study, which is a very short period of time for skeletal physiology. And I think that shows us that we do not need near this high of a dose, most likely. So I think next effort should be focusing on a lower dose and also potentially altering the interval of the dosing. So clearly further study is needed to determine how and when to use denosumab, and this is particularly the case in children. I would argue potentially the most important population to study this in. And there's a lot of important considerations in kids. They have very different skeleton than adults. Children have higher bone remodeling rates. During the first year of life, 100% of a child's skeleton is replaced. In young children, 50% of their skeleton is replaced yearly, and in adults, that declines to 10% per year. Also, unlike adults, only children undergo the process of bone modeling. So that's the process by which new bone is formed, grows out of the growth plates, and is shaped. So because of these differences, denosumab treatment in children will likely have a higher potency. It will likely have a shorter duration of efficacy. And as a consequence, the post-treatment rebound we expect will likely have an earlier onset and will have a greater severity. I think a really critical point that we need to bear in mind is that adults who have severe disease and have very high baseline bone turnover may likely behave very similarly to children. So I think it's important we don't get locked into a pediatric adult mindset. There's a lot of gray area in between. And I just wanted to share, just to reiterate this point, here are 2 patients from our adult phase 2 trial. These were the patients that had the highest baseline bone turnover in the cohort. One of them was a young adult in her young 20s. Another was an adult in her 50s. They were both restarted after the discontinuation period on a moderate dose of denosumab, 120 milligrams every 3 months. And we can see this is their CTX levels, and you can see that they had a sharp decline after each denosumab dose, but that the CTX climbed back to pre-treatment levels in between doses. And in one of these patients, this was associated with progressive hypercalcemia prior to the next dose. So it's entirely possible that we're going to adopt a completely different dosing algorithm based on patients' disease severity and their onset of rebound. So we're currently conducting a phase 2 study of denosumab to prevent FD lesion progression in children. Really the rationale for this is, as you have probably heard yesterday, the natural history of FD is to expand rapidly during childhood in the first few years of life, for the expansion rates to kind of decline as children get older, and final disease burden is fully established in early adulthood. So that provides us a really important window of opportunity where if we can find an intervention that will disrupt that process and prevent the FD lesions from either being established or from expanding, that's how we can truly have a transformative effect on the disease. So this study will enroll 10 to 15 children aged 4 to 14, and our primary endpoint is going to be looking at change in skeletal burden score over a 1-year period compared to untreated historical control children from our natural history study. So we have a cohort of 31 children with serial bone scans that we'll use as a comparison. Based on our findings in the adult study, we're going to adopt a much lower dose, 0.25 milligrams per kilogram. However, we're going to give it frequently. We're going to continue monthly dosing to try to avoid the rebound in between doses. So altogether, it's about a 10-fold decrease in dose compared to the adult study. So we have a number of safety endpoints, including monitoring dentition, skeletal imaging to look at effects on non-FD bone and growing bone, as well as, of course, mineral metabolism. And we've built in extremely stringent discontinuation procedures. So zoledronate will be given at 4 and 8 weeks after the final dose. We'll also give additional doses of denosumab as needed to try to mitigate or slow down the rebound process. And because we can see such potential clinical benefits of denosumab, we built in a process by which, if it's clinically indicated, if in our view the children are at risk for high morbidity or reduced quality of life off denosumab, we can restart the medication at any point in the discontinuation period, which I think is an important ethical consideration. So I just wanted to also close by sharing some information about another exciting study that we are conducting, and this relates to treatment of FGF23 excess in fibrous dysplasia. So as we heard yesterday, FGF23 is a phosphaturic hormone that is produced by FD cells. And the amount of FGF23 that's produced in each individual really seems to parallel their overall amount of FD that they have. When FGF23 levels climb high, it can have effects on both the kidney and the GI system to increase urinary phosphate excretion, reduce GI phosphate absorption, and the net effect is a lower blood phosphorus level. And this is important in fibrous dysplasia because we can see that FGF23 excess can increase skeletal morbidity. It can cause rickets, osteomalacia, and for quite a while we have observed that patients with FD appear to be particularly vulnerable to the hypophosphatemic effects. So this graph here shows a review of 240 patients from our natural history study, where we showed that even low normal phosphorus levels, so at the bottom of the normal range, were associated with higher risks for fractures and orthopedic surgeries. So putting this together, the data seems to suggest that patients with FD could benefit from maintaining high normal phosphorus levels to help protect their bones. So medical treatments for FGF23 excess historically have been extremely unsatisfying. Conventional therapy involves giving oral phosphate, which has to be given frequently, 3 to 5 times per day, and is often limited by GI side effects. This has to be combined with treatment with active vitamin D analogs, and that treatment is often limited by increased urine calcium, and which can cause nephrocalcinosis. So putting this together, while this treatment can be partially helpful, it cannot feasibly normalize serum phosphorus levels. So Burosumab is a more targeted, newer approach. It's a monoclonal antibody to FGF23 that has been studied in other FGF23 excess disorders, including X-linked hypophosphatemia and tumor-induced osteomalacia. And satisfyingly, it can completely correct hypophosphatemia in those conditions safely without increasing urinary calcium, can improve function, it's extremely safe. It's also extremely expensive, on the order of $200,000 per year, and it's not been studied or approved by any regulatory bodies for treatment of FD. So we're conducting a phase 2 trial of Burosumab for treatment of hypophosphatemia and fibrous dysplasia. This study will enroll 10 to 15 patients, and it will target both pediatric and adult patients. The primary endpoint is going to be the proportion of patients achieving a high normal phosphorus level. So based on our natural history data, we're going to be targeting an age and sex-adjusted Z-score between -1 and +2. Safety endpoints will be primarily effects on FD lesion activity. We don't have any reason to suspect that Burosumab will worsen FD lesions. However, I think it's worth bearing in mind that this is dysplastic tissue, that it produces FGF23, and this is potentially the only prospective study that will be performed with this medication. So we want to rigorously look at what it's doing to both lesion activity and to tissue. So we'll be performing pre and post-treatment bone biopsies in adult subjects. And enrollment for this study is near complete. And I just also want to shout out Hassan Gunn, who is the lead associate investigator of this study, as well as Dr. Vivian Shimchuk, who is the lead AI of the pediatric Denosumab study. So just wanted to thank, of course, my group, the many wonderful folks we work with at NIH, including Mike's group, and none of this would be possible without our amazing patients and families. So thanks very much.
That was fantastic, Alison. Any questions from the audience? We've got 5 minutes. Right, question at the back.
Alison, this isn't a question. This is a compliment on your presentation and just an explanation, as you and I have spoke in the previous days. I am one of those patients that does have significant polyostotic fibrous dysplasia. I am also on Denosumab, and I am also one of those patients that gets 120 milligrams every month. And we have seen when we try to wean off of that significant amount that often, that the bone markers do spike. Mm-hmm. And we have spoken, and we're going to have some interventions with my current endocrinologist, and I look forward to that. But in regards to the Denosumab and what it is doing, it's doing phenomenal things with the fibrous dysplasia reacting of the cells. So I just wanted to confirm, being a patient, that is what we're seeing. Thank you.
No, thank you for sharing that. I think it's an excellent point. Yeah. And just to reflect on that, I appreciate you highlighting that it's a very heterogeneous disease, and no two patients look alike. And just to kind of back onto what one of Dr. Collins' comments is, I think one thing we've done well in fibrous dysplasia is we've been able to hold that heterogeneity and make sure that when we do research, we're prioritizing the needs of both patients with milder disease involvement and more extensive disease involvement. And I don't think that's always been done well in every rare disease, particularly in trials of osteogenesis imperfecta. They have mainly enrolled patients that have the mildest form of OI, and then they'll see benefit of their medication. But then when we take that data and try to apply it to the most severe patients, we don't see the same efficacy. So I think understanding that the needs of everyone are important, and really centering the highest, more patients with the most need is important.
Great. Are there any other questions for Alison? Yep.
Do you have any documentation that we can give to a insurance company that states that high normal levels of phosphorus are important for FD patients because, like you said, $200,000 a year for Burosumab is a lot
It's
for insurance
bonkers.
companies.
Yeah.
And when you have a child who's already on over $1 million of medications, they're trying everything they can. So they see a normal level, a 3.5 of phosphorus, and they said, oh, we're not going to increase the dose.
Yeah, no, thank you for bringing up that point. And we're trying to be very conscious about that in this study. So this study is investigator-sponsored, so it's not sponsored by the pharmaceutical company, but we are collaborating with them. And my hope is that we designed this study very thoughtfully so that if it does end up applying for an indication, either for the FDA or an EMA, it was designed to target a high normal phosphorus level, and it will hopefully show that that is safe therapeutically. So I'm hoping that will ultimately become the standard of care in fibrous dysplasia if the results of this study are supportive. And you can't control insurance companies, but all we can do is do the studies as best we can and make the data as clear as we can. So.
Thank you so much.